Hello and welcome to a new episode of the Diabetes University. I am your host, Dr. Sharif Yaqub. In this episode, we will talk about the diagnosis of diabetes and prediabetes. Let's start with a question. Which of the following asymptomatic patients meets diagnostic criteria for diagnosis of diabetes? A 42-year-old male patient with a hemoglobin A1C of 6.3%, fasting glucose 104, a 66-year-old male patient with a hemoglobin A1C of 6.4%, fasting glucose 119, 2-hour glucose after a 75-gram glucose load 205 milligrams per deciliter, or number C, 52-year-old female patient with a hemoglobin A1C of 6.7%, fasting glucose 108. Option D includes both B and C, and option E is all of the above. The correct answer is B and C, and we will see in the next slide why I chose that answer. Diagnostic criteria for diabetes include a hemoglobin A1C more or equal to 6.5%, as you can see here, or fasting plasma glucose of more or equal to 126, 2-hour glucose in a glucose tolerance test more than 200, or a random plasma glucose with symptoms of hyperglycemia of more or equal to 200. The symptoms of hyperglycemia include dry mouth, polyuria, polydipsia, fatigue, and weight loss. Now, the criteria for prediabetes or borderline diabetes include a hemoglobin A1C of 5.7 to 6.4%, fasting plasma glucose from 100 to 125, plasma glucose after 75 grams of oral glucose tolerance test between 140 to 199, and that is the diagnostic criteria for both prediabetes and diabetes. Now you may have questions about this slide. How did they come up with these numbers? Was there an auction where some endocrinologists suggested 125 for diabetes and then somebody else suggested 126 and they won the day? Was there a poker game where somebody suggested 126 or higher numbers? Or did they argue between 125 and 127 and came to a compromise of 126? As fun as all of these options might be, they are not correct. The correct answer is far more boring than this, and it goes back to an article that was published in the British Medical Journal long time ago. That article aims to find a correlation between the incidence and the prevalence of retinopathy as functions of glucose values. So basically here you see in the slide the 5-year incidence of retinopathy and the 5-year and the prevalence of retinopathy as functions of 2-hour plasma glucose, fasting plasma glucose, and hemoglobin A1C. Now they noticed that these numbers and the prevalence and the incidence both tend to take off considerably when the glucose levels are more than 6 millimoles per liter fasting, and the 2-hour plasma glucose is around 11 millimoles per liter, and the hemoglobin A1C is around 6.5%. So because this article is published in the British Medical Journal and they used the millimole per liter rather than the milligram per deciliter, then they had to translate these numbers from millimoles to milligram per deciliter. How did they do that, and what was the result? So it turns out that 7 millimoles per liter is equivalent to 126 milligrams per deciliter, hence we get the number 126 fasting, and 11 millimoles per liter is around equivalent to 196, but they decided to not be jerks and round it up to 200 to make it a bit easier for everybody. Now, it's very important to understand what is normal when it comes to glucose balance. The experts that study forging at the FBI, they don't really study forgeries of money or banknotes. What they study at length is what the original note looks like, what the correct official banknote, dollar, basically looks like and what it contains. And when you are very familiar with the normal, then the abnormal will become evident. Normally, your glucose level should not exceed 120 milligrams per deciliter, even after eating. And this is something as endocrinologists you might encounter, or as doctors who want to specialize in managing diabetes or want to help people with diabetes, you might hear this, that the patient says, well, I just ate, or I just had something to drink that had sugar in it. Well, even though it should not exceed, the glucose level should not exceed 120 at any given point in time. Now, the cutoff for the pre-diabetes in a 2-hour glucose tolerance test is 140, and the cutoff for the diagnosis of diabetes on a 2-hour glucose tolerance test is 200 milligrams per deciliter. Now, some of you may say, but I do seem to recall a number that is different from what you just mentioned. I seem to recall that the number hemoglobin A1C 7% is important and is included in some criteria. So what is that, and what is that difference between what you just said and the other numbers that we have previously heard? Well, that's an excellent question. There is a difference between the diagnostic criteria and treatment targets. Let me explain. The criteria for diagnosis of diabetes apply to somebody who is not known to have diabetes, and you are diagnosing them for the first time. And as we just agreed, we're using the cutoff of hemoglobin A1C 6.5%, fasting plasma glucose more or equal to 126, and 2-hour postprandial plasma glucose more or equal to 200 milligrams per deciliter. However, once somebody is diagnosed with type 2 diabetes, our target now is different. We're not trying to get them below 6.5%, at least according to ADA criteria. We're trying to get them less than 7%. There is considerable debate about this number and whether it should apply to everybody or not, and I'll save you the suspense. It shouldn't, and we'll learn as we go along some modifications that are necessary for the treatment target. But in general, hemoglobin A1C of 7% is considered desirable. The preprandial plasma glucose, according to the ADA recommendations, should be 90 to 130, and the peak postprandial plasma glucose should be less than 180. That's the set of numbers to be applied and to be used as goals of treatment of type 2 diabetes. Now let's summarize what we just learned. First, diabetes is diagnosed with a hemoglobin A1C of 6.5% or more, fasting glucose of at least 126 fasting, or 200 milligrams per deciliter 2 hours after a glucose load of 75 grams, or random glucose more than 200 milligrams per deciliter with symptoms of diabetes. Notice that the letter or the conjunction or is highlighted and underlined because it's important. You don't have to have all of these things to diagnose diabetes. There is a considerable delay in diagnosis. A lot of people are still undiagnosed, and so the ADA has been pushing for ease in diagnosis so that we can start acting on the blood sugar from the get-go and help patients improve their glucose control. Now, you'll read some places that it says that the fasting glucose of 126 needs to be repeated, and that might not be present in some other resources that you will read, but I think it makes good clinical sense. Because if somebody had a fasting glucose of 127 just one time, and you are not sure about the fasting state, you're not sure about effect of other medications or whatnot, it is good practical clinical sense to just have them repeat the test and explain very well the precautions that they need to take, especially with the fasting duration of at least 8 hours, if not more, so that you can be certain of where they fall within the diabetes spectrum. As for prediabetes, it is diagnosed with a hemoglobin A1C between 5.7 and 6.4%, fasting glucose more than 100 but less than 126, venous glucose 2 hours after a 75-gram glucose load more than 140 but less than 200. And by the way, these criteria all apply to a venous sample of glucose. They do not apply to a finger stick glucose that you check on any machine, because a machine might not be accurate. We're talking about venous samples. The criteria of diagnosis are different from treatment targets for patients with established diagnosis. I hope this clarifies a few points for you, and until next time, farewell.